Thank you. Yes. Good morning, everyone. My name is Kirsty Buising, and welcome to the NCAS Journal Club for this month. We've got 3 speakers this morning. The first little bit under half an hour is going to be myself and Jaclyn Baker, who are both going to give a feedback session on a recent conference that we attended. And then after that, we're very excited to have a special speaker, Ruby Biezen, who's going to be talking to us a little bit about her PhD. So we might launch in and move through our presentation quite quickly. So the conference that we're talking about is the Antimicrobials 2017 conference that was held in Adelaide toward the end of last month. And I've got a disclaimer up front that the information from this largely comes from my notes. The PowerPoints weren't yet available online, and so it clearly represents my interpretation or understanding of what the speakers said. And I also want to make a disclaimer that I have no expertise in genomics, and that's going to become very relevant once you hear what I'm talking about. So Jaclyn and I have divided the feedback session, and I'm going to be talking a bit about a topic that was very prevalent at the conference. I'm going to be talking about the microbiome and antimicrobial resistance, and Jaclyn's going to talk a little bit more about antimicrobial stewardship specifically. So for those of you who've been to the Antimicrobials conference before, this focus on microbiome, I think, was a bit of a shift in the way it was presented, and my personal impression was that it was really heavy on microbiome stuff this year. So I'm going to talk about a couple of the speakers who impressed me and just some points that I took home from the learnings that I made from the conference. So the first one came from the very first plenary speaker, the first lecture of the day, which was a gentleman named Geraint Rogers from South Australia. And his topic was the microbiome and AMR. And one of the first things that he spoke about during his talk was that he really wanted us to focus on talking about the resistome now rather than the microbiome, because the antimicrobial resistance genes can be in or out of the bacteria, and so it's more general to talk about the resistome. His talk focused a bit on the environmental microbiome or resistome and how it is much more complex than that's associated with humans. He spoke about the fact that in external environmental niches there are lots of naturally occurring antibiotics, and most of them exist at not bactericidal concentrations. So they're not killing the competitive bacteria around them. And he thinks that their role is likely to be to manipulate the microbiome locally. So the organisms that this particular bacteria might be, or fungus might be competing with, there's a competitive advantage there. So he says that we can find lots and lots of genes around antimicrobial resistance because of that, and that these genes are very, very ancient. And he thinks there's many, many more antibiotics or antimicrobial drugs to be found in the external environment. One really important point that came from a science paper published in 2012 that he spoke about was the fact that the resistome of soil can transmit to human pathogens, and that there's evidence of antimicrobial resistance cassettes in soil that match those in bacterial pathogens locally around that environment. Now, how am I going forward here? Click on the screen. Sorry. And this little graphic comes from that science article. So what was trying to be described here are 5 common human pathogens. You'll see down here Pseudomonas, Acinetobacter, and different types of Salmonella. And then these antimicrobial resistance cassettes that have actually come from environmental bacteria, and they carry genes for resistance to beta-lactams, aminoglycosides, tetracyclines, sulfonamides, and chloramphenicol. And the grey shading indicates there's more than 99% homology between the genes in these groups, and the light grey, which you can hardly see, but that indicates more than 88% homology. So what he's saying is that these resistance cassettes seem to be shifting from soil pathogens into human pathogens, and I think that's a really important observation. The second point that he made was around this concept of a population resistome, and he spoke about this paper published in Genome Research. The title was Country-Specific Antibiotic Use Practices Impact on the Human Gut Resistome. And what they did in this study was they took faeces and did metagenomic studies from people in Spain, Denmark and the USA, and they had 252 samples. They looked at the different types of resistance genes and on average described 21 different resistance genes per person. But what was interesting in this paper was there was a correlation between the number of resistance genes in the faeces and the volume or type of antibiotic use in agriculture in that particular country. And that graph comes from the paper, with the blue line being Danish, green American and red Spanish. And what he pointed out in his talk was that in the USA there was high macrolide and lincosamide use in agriculture, and thus the resistance genes to those pathogens were much more prevalent, whereas vancomycin had only previously been used, or vancomycin-like drugs had only previously been used in agriculture in Europe, and that's where you saw the resistance genes in the faeces in that particular population. There was a discussion around circulation of the resistome, and the paper that was described came from Nature, and its title was Interconnected Microbiomes and Resistomes in Low-Income Human Habitats. So in this particular paper, they took samples of soil, animal faeces and latrine samples, so human faeces, from samples were taken from El Salvador and Peru, and they did shotgun metagenomics to look at different antimicrobial resistance genes. And what they described in this paper was the same antimicrobial resistance genes were found in different samples from the same site. So the human latrine samples matched the soil samples in, for example, Peru or El Salvador, but the different sites had different genes circulating. And there were really interesting graphics in that paper that were quite hard to understand. But what this is trying to describe is the round ones are human, the triangle ones are external environment, and the distance away is the degree of genetic difference. And what they're trying to show is that the human and the environmental ones are overlaying on each other for different locations so that they're matching up. The diversity of the resistome was another concept that he described, and the paper was a 2016 paper titled The Structure and Diversity of Human, Animal and Environmental Resistomes. Now, this paper got a mention by a couple of speakers in the conference, so I think it's an important paper to know about. What they did is they took human, animal and environmental samples from which the metagenomic sequences had been published in available literature. And there were in total 864 metagenomic deep sequencing of samples done. And they looked at the diversity, abundance, and then looked for correlation between these sequences. And what they described in the paper was that in human and environmental samples, there was a low diversity of different antimicrobial resistance genes. There was a low frequency of biocide or metal resistance genes, but there was a high volume of antimicrobial resistance genes or abundance, whereas in the environment there was lots of diversity, there was high rates of metal and biocide resistance, and that antimicrobial resistance or drug resistance genes were low in abundance generally. And also the environmental samples had high rates of mobile genetic elements as well. The highest antimicrobial resistance genes abundance and variety came from samples that were most affected by industrial pollution. So the highest density of antimicrobial resistance genes came from sludge or river samples from pharmaceutical waste, so rivers that were near drug manufacturing plants. The highest number of different antimicrobial resistance genes came from samples from Buising smog, so they were air samples. And also the correlation between human and animal and other environmental antimicrobial resistance genes was highest for these Buising smog samples. So this was the graphic that they showed a couple of times during the conference. And what they're trying to show is blue is low, red is high. And you can see the different sites where the samples have taken. And this is looking at correlation. So this is the antimicrobial resistance genes themselves, and this is the different types of bacterial genera found in those samples. And really the take-home message was the dark red was coming up in Buising smog. That was the highest correlation with all of these different samples. So these genes are floating around us like a cloud, and they're moving in and out of these environmental samples all of the time. And the last important point that I took from that plenary was around managing or changing the resistome. So he discussed using fecal microbiota transplantation to address colonisation with antimicrobial resistant pathogens. So he spoke about two different studies, one where fecal microbiota transplantation was given for treatment of Clostridium difficile to people. So that was their intention when they gave the transplant, was to treat C. difficile. But they happened to take fecal samples from these patients before and after and look at the prevalence of antimicrobial resistance genes as well. And what they saw was that antimicrobial resistance genes fell post the FMT. He then spoke about using an animal model, a mouse model, that specifically used FMT to treat colonisation with multi-drug resistant bacteria. And the mouse model looked at KPC, or Klebsiella pneumoniae with carbapenemase, and VRM. And what they found was that, I'll show you the graphic in a moment, but that FMT was able to completely eliminate KPC colonisation in these mice, and it dramatically reduced VRE colonisation in the mice. And he spoke about the likelihood being that we may be moving into a time of what he called next generation probiotics. So the idea that the intact microbiota can resist invading pathogens, and that we may actually be giving our patients proactively these mixtures of probiotics to try and help them resist infection. And this is a little graphic from that paper. So they took the mice, they pre-treated them with ampicillin to drop their other pathogens that were in their gut. They seeded them with VRE, or Klebsiella pneumoniae. And then during a period post the antibiotics, they gave them an FMT, so repeated fecal microbiota transplantation, and then took samples afterwards to look at the resistance. And these are the placebo-treated mice, these are the FMT-treated mice, and what you really need to see is before treatment, the red ones, which are the Klebsiella, are very high, and then after the FMT, they disappear completely, and the green ones dramatically drop in number. There's still a few VREs being seen in the samples, but not all that many. So I'll move really quickly through this last bit. So Tim Walsh was the big famous guest speaker who gave the Floria oration. So as you know, he's the guy who described NDM in the sludge water in India. And the concept I took from his talk was this thing called the phantom resistome. And what he was saying was, if we rely on looking for resistance in cultural bacteria, we're missing well over half of them. And he discussed the problem that lots of antimicrobial resistance genes were being found in samples, but by PCR, where the bacteria were completely unculturable. So that when you're able to do this genetic sampling, you can find evidence of NDM, you can find evidence of MCR1 in flies, you can find evidence of these MDR pathogens in dogs, but you can't culture the bacteria that demonstrate it. Anton Pellig from Victoria gave a talk on the GIT as a reservoir for resistance genes, and the points I took away from his talk were he discussed the effect that antibiotic use has on the prevalence of antimicrobial resistance genes, and he says that during antibiotic use the bacteria have an SOS response, so a please help me response, where they become hypermutatable and they're exchanging genetic material more often. If those bacteria, if you look at chromosomally encoded resistance genes from that bacteria, you see a spike in the amount of those genes during antibiotic treatment that goes down afterwards, so that the bacteria stop making those genes once they no longer have to make them to combat the antimicrobial that's being used. But for plasmid-encoded genes, you see an increase during antibiotic use, and that persists thereafter. So what we're saying there is the likelihood is that those resistance genes have moved to other bacteria. So even if that bacteria isn't requiring it anymore, it's hanging around in the gut long term. Anton spoke about how to look for resistance and this important difference between culture, where we traditionally did antibiotic susceptibility testing or molecular testing on cultured bacteria, and metagenomics, which he spoke about as really being the future for how to look for resistance. But he mentioned the important difference between targeted, functional and sequence-based metagenomics. So targeted being where you have a PCR and you're looking for a known gene, pretty straightforward. Functional being important because he said this is the one type that allows you to look for resistance that you didn't previously know about. So he spoke about how that's done, whereby you fragment the DNA, you clone it into an expression plasmid, you put the plasmid into host E. coli strain, and then you test that E. coli's phenotype on media. So you grow it and expose it to antibiotics, and you see if it's resistant to those antibiotics. And what this technique allows you to do is identify novel resistance genes. So he said that was very important to be doing, so that we're discovering new things and we're not just looking for what we already know. And then clearly the third one was sequence-based or next-generation metagenomic testing, where you do a whole genome sequence and you align it to known genes. So obviously that's only looking for things that you already know about. And the last point I'm going to make was an interesting symposium talk by a guy called Alkis Satalis, and he's actually an ENT surgeon in South Australia, and he spoke about the microbiome in chronic sinusitis, and I think I learnt a lot from this talk actually. So chronic sinusitis is the commonest respiratory disease in all ages. It affects 10% of the population. It obviously happens for heterogeneous reasons: allergy, polyps and anatomical defects, and importantly infection, we know can cause chronic sinusitis. But the point Alkis was making was that sinus cultures don't detect organisms in biofilms, and we find a whole lot more if we do next generation sequencing. And what he said was if a particular bacterial species makes up more than 10% of the population by next generation sequencing, then you've got about a 50% chance of culturing it when you take sinus secretion samples for culture. If the species makes up less than 10% of the population by next generation sequencing, you've got less than 5% chance of culturing it. So we're missing the bulk of what's actually going on there because these organisms are living in biofilms. He also pointed out that healthy sinuses contain bacteria that we usually recognise as pathogens. So he said the most prevalent bugs were Propiones, Staph epidermidis and Corynebacteria, but naturally occurring you will find strep pneumonia, Moraxella and Haemophilus, and they're not necessarily pathogens, they're just there. And his I guess, thesis of this whole talk was that chronic sinusitis is not the result of one particular pathogen necessarily overgrowing, it's the result of a dysbiosis in general. He spoke about the fact that in people with chronic sinusitis, you see lower abundance of lactobacillus and increased abundance of Corynebacteria, and you see reduced diversity of different genera in the sinuses. And he spoke about an animal model of chronic sinusitis where they instilled Corynebacteria and they saw on biopsy of the sinuses increased goblet cells. So that's a marker of sinusitis, active sinusitis. And then they added lactobacillus alongside the Corynebacterium and the goblet cells went down again. And when they put topical probiotics, so a Staph epidermidis that was instilled, they saw the goblet cells go down again. So again, this notion that probiotics or actively manipulating the microbiota might actually help to combat infection. And there's an interesting review article that's worth a read around the microbiome and sinusitis. And my very last slide is about a new therapeutic approach that he spoke about. So in South Australia, they have one particular patient who had 14 procedures to try to manage his sinusitis and they'd all failed. And so they obtained mucus from his healthy wife, they got TGA approval and they did a snot transplant. And it was only done in February, so it was only a couple of weeks since this had been done. But he said, we're all waiting with bated breath to see how it's gone. So I thought this was a really interesting way to end and to think about what sort of therapies we might be moving to when our antimicrobials don't work anymore. So I'm going to stop talking and quickly see if we can segue to Jaclyn, who is going to talk from Ballarat. So she's a couple of hours away. And we're just going to get her slides up and see if we can change speakers. Jaclyn, can you hear us?
She's connected to audio. Hi, Jaclyn, are you there?
Okay, everyone, sorry for that delay. We're still trying to get Jaclyn sorted, but because of time, I'm going to try to move forward. Arjun's still going to keep going, trying to get Jaclyn sorted, and if we can get her to take over, we will. But I was at the same talks that Jaclyn was at, so I think I can probably speak to her slides. Okay. So we're coming back to okay, so if it suddenly works, she'll take over from me. But Jaclyn's slides were going to discuss, she was going to discuss a couple of talks that were in a session that was specifically on antimicrobial stewardship. The topics she was going to cover were around antimicrobial stewardship team recommendations, their acceptance rates in the acute versus the rehab setting, a zero tolerance policy for pre-authorisation, supporting patient safety and antimicrobial stewardship during antimicrobial shortages, and interrogating the NAPS data to propose new targets for regional, remote and rural hospitals. So the first the first study that she was reviewing was presented by Matt Rawlins from Western Australia, and he was looking at the acceptance rates of their AMS team's recommendations in their acute hospital versus their rehab service. And he discussed the fact that their acute hospital does daily AMS ward rounds, whereas the rehab service had once a week ward rounds at a fixed time. That in the acute hospital, they communicated directly with junior medical staff or entered recommendations in the medical record, whereas at the rehab hospital, there was a direct liaison with the whole medical team. So generally the trainee registrar level and entry into the notes. But their percent of recommendations disregarded were actually different, that the acute hospital were more likely to reject recommendations compared to the rehab service. And this was different to a perception. When they'd gone into this study, their perception was that maybe the rehab team weren't following them as well. But in fact, that what they found was the acute hospital wasn't following the recommendations as well. And the percent of route change recommendations that were disregarded were much higher in the acute hospital. So that may reflect a significant reason why their recommendations weren't being followed, because they weren't making IV to oral switches, for example. Okay, moving forward. The zero tolerance policy for pre-authorisation was presented by Suman from St George's Hospital in Sydney, and this is a hospital that has had guidance for some time to the software that they use to manage their approval system for restricted antimicrobials, and they were making a change in their policy such that it was no approval, no dispensing. So this was really coming down hard. And it was marketed as a zero tolerance policy. They were worried that the policy was supposed to occur between 8:30 a.m. and 5:30 p.m. during the day, and it didn't operate in the evenings and night time, and it didn't operate on weekends. So they had to be looking at whether there was any gaming of the system. So they wondered about whether people would delay trying to get hold of their drug until after 5 o'clock, and other things were there any delays, for example, in patients getting their medication. So they had to do a structured study to try to make sure that this was safe. And they compared their pre- and post-approval situations, and what they found that was post this system going in, the number of approvals per month jumped by a third. The dispensing fell slightly, and that after hours dispensing there was only a slight increase. So this was what they really wanted to watch in terms of gaming, and it didn't look like there was a major problem. And overall there was a 12.2% absolute increase in adherence to pre-authorisation. So they saw this program as having been successful. One of the speakers from the Clinical Excellence Commission spoke about the way that the CEC has supported hospitals during the antimicrobial drug shortages. And she spoke about applying a model for managing medication shortages in general, and the fact that they had a team that assessed how they would manage this, and they spoke about acyclovir, metronidazole and vancomycin as examples of what they were doing. I've just noticed there's actually some slides missing from Jaclyn's talk here, but she did actually have some slides from the process that they undertook to work this out. But essentially they had a risk register where they were looking at whether the risk was high or low, and a process whereby they were able to try and address and mitigate the risk. So the CEC was doing this as a collective activity to try to support smaller hospitals who perhaps didn't have the facility to manage the shortage on their own. And the last set of slides that we're speaking to is Jaclyn's own presentation, which she was looking at the NAPS data for rural and regional hospitals to look at whether there were targets that we could be looking to for those hospitals in particular, to look at the quality of the stewardship program. And what she basically found was that prescribing was marginally but statistically significantly more likely to be inappropriate in rural and regional hospitals compared to urban hospitals. And then she drilled down looking at the reasons for inappropriate prescribing and saw that two of the most common indications that were marked as inappropriate in rural and regional hospitals were community-acquired pneumonia and management of chronic obstructive pulmonary disease. And so these stood out as likely targets that needed some intervention in that setting. She also highlighted cellulitis as an indication for which people were frequently inappropriately prescribing antimicrobial drugs in the rural hospitals. She saw that compliance to existing guidelines, I'm just trying to remember your findings from that, Jaclyn, but I think the findings were that the guidelines existed, but people were more likely to not be compliant with them in the rural and regional hospital. And she also did a drill down to look at high-risk indications to see how common were we encountering those in the rural and regional hospitals. So she looked at prosthetic joint infection, endocarditis, meningitis, CNS infections of other types, and actually saw that a very significant percentage of people with those indications were turning up in rural and regional hospitals, so that the need for expert intervention in those hospitals was clearly there. And that's the end of Jaclyn's slides, I think. Let me just check. Yeah, it looks like that's it. So I'm sorry for the haphazard finish to the presentation. I'm happy to take questions, though I can see we've gone slightly over time, so maybe I might instead, I'll offer up if there are any couple of questions anyone wanted to ask quickly. Happy to take them.
Just with the Beijing smog, is there any indication how the smog was carrying that, or was it respiratory source, was it the environment, or kind of chimneys pumping that from drug companies?
So I read the paper I've got, and it didn't specify. It called it a smog event. So I think when they have those high rates of pollution, they periodically sort of put out warnings to say there's high rates of pollution at the time. So what causes it? Presumably sort of a combination of the weather conditions that are going on, but the paper didn't postulate on how it was happening. But it certainly, I think, makes us stop and think, because it's not something I'd certainly thought about before.
It could be the dust from farms being kind of in soil, kind of aerosol.
That's right. It might well be. Yeah. They didn't postulate beyond that. Okay. Well, I might invite up Ruby then. So Ruby's a microbiologist by background who has been doing her PhD for the last 3 years at Monash University, and she's specifically looking at antimicrobial use in community practice. So I'll invite Ruby up to speak.
Hi everyone, my name is Ruby Biezen. I'm from the Department of General Practice at Monash University. Look, thank you for the opportunity to present my work from my PhD, and as you can see, the title is Knowledge, Attitude and Practice of Parents and Primary Care Providers in the Prevention and Management of Respiratory Tract Infection in Young Children. So in the next 20 minutes, I'm going to go through the rationale of my PhD, why this is important. I would then present the methodology and some of the results from the research. And as this is a PhD by publication, I will outline the outcome of the PhD in a publication format. And then finally, I will be showing you how I'll use this result of the study to develop an intervention that will hopefully be piloted, evaluated, and finally translated into practice. So respiratory tract infections are very common, and over 6 million general practice visits are managed annually in Australia and represents a significant health and economic burden. They are most prevalent in young children under the age of 5, especially when they attend preschool or daycare centres. It is estimated the cost of the Australian community for managed acute respiratory illness in children aged between 12 months to 23 months to be $241 per episode. So according to the NHMRC and the therapeutic guideline, current treatment and management includes rest and hydration, paracetamol to reduce fever over 38.5 degrees. However, oral decongestions and cough syrups are no longer recommended for children under the age of 6 due to the lack of evidence that they are effective and the possibility of side effects in the age group. So majority of RTIs are caused by viruses, so antibiotics are not warranted as a treatment for most respiratory tract infections. So however, despite Australian clinical guidelines, GP's treatment and management of RTIs in children is not clear. Overseas studies have reported inconsistencies of physicians' treatment and management of RTIs, especially in the use of antibiotics. Factors such as parental misconception regarding symptoms and their understanding of antibiotic use have influenced physicians' management of RTIs in young children. So with regards to prevention, NHMRC guidelines focus on the effective hand hygiene, such as soap and water, alcohol-based hand rubs, hand drying and hand care, sneeze and cough etiquette, and immunisation such as influenza vaccination. So studies have shown that good hand hygiene practice can significantly reduce the transmission of infectious diseases in community settings. However, the lack of time, lack of facility, lack of understanding of the transmission of infectious diseases and attitude to hand washing are common barriers leading to low compliance amongst the healthcare workers. So although hand hygiene has been used widely and been promoted within Australia, the efficacy and sustainability of the practice has not been assessed in primary care. So in terms of influenza vaccination, or in terms of influenza, it is a serious contagious respiratory disease with estimated annual influenza-associated death to be 250 to 500,000 globally. The highest influenza notification rate in Australia were in the age group of 0 to 4 years. So influenza vaccines have been shown to be effective at reducing influenza-related illnesses, reducing healthcare burden and related costs in vaccinated children, and the Immunise Australia program recommends that influenza vaccination as part of the routine vaccination for individually 6 months of age with chronic conditions and asthma leading to severe influenza illnesses. However, the uptake of the vaccine still remains low, even in that group, even though recent studies in Australia have shown that influenza vaccine is safe and well tolerated for children between the age of 6 months and 10 years. Okay. All right, so we have now identified some important gaps into the management, treatment and prevention with respect to RTIs in young children. So in Australia, GP treatment and management strategy for children under the age of 5, it's unclear. Even with active promotion of hand hygiene, no intervention studies have been done in the Australian primary care setting to measure the efficacy and the sustainability on hand hygiene. Therefore, it's actually unclear whether primary care providers and parents and carers are following these protocols for preventing RTIs, especially in young children. Also in the Australian primary care setting, both parents' view and primary care providers' view on influenza vaccine are not clear, and Australia is one of the few countries that influenza vaccination is not funded for children without coexisting risk factors, even though children less than 5 years of age are most vulnerable to influenza and related illnesses. So to date, there's been limited data exploring RTI management in young children in the GP setting in Australia. Also, there's no study exploring the views of other primary care providers, such as your practice nurses, maternal child health nurses, and pharmacists. And they are a valuable group of health professionals because they're most likely to have more contact with children under the age of 5 than children who are older. And they often provide advice to parents independently from the GP regarding child's health. So the aim of my PhD is to examine and thereby understand the current knowledge, attitude and practice of parents and primary care providers in managing respiratory tract infection in young children. So by identifying the barrier and enablers, we can then design an intervention that will increase awareness of managing and preventing respiratory tract infection for primary care providers and parents to better manage in this age group in the primary setting. So the research design of my PhD is based on the UK Medical Research Council framework for the development and evaluation of complex interventions. So the UK MRC framework consists of 4 phases, including the development phase where evidence is gathered to develop a theory towards an effective intervention. The feasibility and piloting phase is used to design an intervention and test the procedure for its effectiveness. Evaluation phase is to assess the effectiveness of the intervention, including the cost, and the implementation phase includes the dissemination of the intervention, surveillance monitoring as well. So my PhD consists of the development phase and part of the feasibility phase. So I'm going to go through the overall structure of my PhD and how that was set out. So the overall structure of PhD was around understanding the current knowledge and views of primary care providers and parents and carers to answer questions like, how do we manage respiratory tract infection in young children? How do we prevent respiratory tract infection? Or is it actually about reducing the transmission? Are there any dissonant views between the primary care providers and parents and carers? What intervention can better assist and better manage RTIs in young children? So the PhD started with a literature review, and it was then backed up by a quantitative study using a beach study, which led us to the qualitative studies and resulting in 4 proposed papers, which I'll go through a little bit later on. And we can then propose, so from studies 1 and 2, we can then propose an intervention design to help primary care providers and parents and carers to better manage RTIs in young children. So the first paper was the quantitative studies. So I'll go through these results really briefly. I just want to have a couple of take-home points for you per paper. So the first paper is the quant paper that we explore the current GP management of RTIs in young children under 5 in Australia using the BEACH dataset. So what we found was upper respiratory tract infection had the highest rate of over-the-counter medication advice. Male GPs prescribe antibiotics for upper respiratory tract infection significantly more than female GPs, and older GP prescribe antibiotics for upper respiratory tract infection more often than younger GPs. So finding of our paper show that was highlighted in MJA that GP management of RTIs in Australia vary according to the clinical problem managed, the age and the sex of the GP. However, the reason for the variation is not clear, so this brings us to the next study, the qualitative component of my PhD. So for the qualitative component methodology, the framework I've adopted is the Susan Mickey's theoretical domains framework. So the TDF is a framework consisting of 14 domains that understands behaviour, therefore leading to the development of behaviour change interventions. So you can see those 14 domains, knowledge, skills and so forth there. I've used the framework as well as the current literature to develop my interview and focus group questions. So for example, the question I asked was, do you mention hand hygiene as a prevention strategy to your patient or parents? So that comes under the memory, attention and decision processes of the TDF domain. It's promoting influenza vaccination proactive. Do you have a recall and reminder system? That actually comes under behaviour regulation. So at the end of the qualitative and the quantitative study, an intervention will be designed using the TDF and the COM-B model. So the COM-B model was also developed by Susan Mickey and the group. For a given behaviour to exist, the three conditions, capability, opportunity and motivation, must be met. So the TDF and the COM-B system will be used to identify targets for behaviour change intervention for pilot study in the feasibility and piloting phase. So this is my qualitative recruitment. I recruited 30 primary care providers for semi-structured interviews. So that included 20 GPs, 2 practice nurses, 3 maternal child health nurses and 5 pharmacists across metropolitan area. I've also ran 5 parents focus group consisted of 50 parents, and that included a very simple questionnaire and also a focus group. So these face-to-face interviews and focus group were audio recorded and transcribed verbatim. 2 of us coded the first 3 transcripts, compared and refined the codes, then read the next 3 scripts and further refined the codes until all the transcripts were coded. Data were then managed using NVivo 10. Themes were developed and later matched to the TDF framework. So this is the first of the 4 qualitative paper, which aim to explore primary care providers' view on managing RTIs in young children. So we found that many factors such as GP's time constraint, parents' anxiety, perceived parental pressure were some of the reasons why guidelines were not followed. Delayed prescribing of antibiotics was mentioned by GPs as a strategy to handle demanding patients. So these emotional and psychological factors influence the decision-making process when it comes to managing RTIs in young children. Intervention to improve communication between primary care providers and parents could reduce unnecessary antibiotic use, and educating parents on RTI symptoms may also alleviate parental concern. I'm happy to say that the paper was published last week in MPJ Primary Care Respiratory Medicine. So in terms of recommending influenza vaccination to children under the age of 5, this study aimed to understand primary care providers and parents' view on their knowledge and acceptance of influenza vaccination in the age group. So we found that primary care providers have concerns regarding the efficacy of the vaccine, administration schedule, cost, and the uncertainty of the morbidity and mortality in the cohort. So while parents have similar concerns, they also believe that the vaccine caused influenza, and it was not necessary because influenza was not severe and children needed to build their own immunity. So the study has demonstrated a gap between influenza vaccination recommendation and primary care providers and parents' knowledge and practice. So the interventions such as practitioner education and increased parents' knowledge are required to overcome barriers identified in the study. So we know that antibiotics are not recommended for treating common RTIs. However, studies in Australia and overseas have shown this practice is still widespread. So the aim of the study was to compare and contrast GP and parents' perception regarding antibiotic prescribing for managing RTIs in young children. We found there were dissonant views regarding antibiotic prescribing between GPs and parents. So GPs believe that parents expect antibiotics and felt pressured to please the parents. GPs also feared that parents will seek antibiotic elsewhere if they were not given antibiotics. So in contrast, parents expressed their main expectation from their GP was to obtain a diagnosis for their child's illness, reassurance that their child was okay and not necessarily expecting antibiotics. They have also stated that the satisfaction of the GP visit was not dependent on receiving antibiotics and that they would not seek another GP if antibiotic was not prescribed. So interventions such as targeted training may therefore improve GP confidence, and parent-GP communication may reduce unnecessary antibiotic prescribing. So the last paper from the PhD, it's hand hygiene in young children. So one of the ways to reduce transmission of diseases such as RTIs is good hand hygiene practice. So this study aimed to explore the knowledge of RTIs transmission and practice of hand hygiene in parents of young children and primary care providers. So while all participants agree that hand hygiene practice is important in reducing RTI transmissions, barriers such as lack of hand hygiene practice amongst primary care providers and not thinking that they need to mention hand hygiene during consultation were mentioned. So parents would remind their children to wash their hands at certain times. However, some parents were worried that the children can get obsessed with hand washing and that they're already too clean. So education for primary care providers and parents on effective hand hygiene is required to promote good hand hygiene practice. Okay, so in this PhD we use a quantitative and a qualitative study to look at current knowledge and practice of primary care providers and parents into the management and prevention of RTI in young children. So we explored the current GP management. We looked at the management of RTIs in young children from other primary care providers' perspective. We've explored the views of GPs and parents regarding antibiotics, and we also looked at influenza vaccination and hand hygiene as prevention strategies to reduce RTIs in young children. Now that we've taken the first step to understand these behaviour, we can work towards designing an intervention to solve these problems. However, due to the limited time and funding, I have to choose one area to target behaviour, even though I like to do all of them, that I will hope to work on. So how do I do this? So in order to select the target behaviour, we need to look at the impact of behaviour change and the likelihood of the changing behaviour to determine the feasibility of an intervention. So a research dissemination session with primary care providers who participated in my research is scheduled at the end of March, and the purpose of the session is to disseminate my results and also identify important priority areas for these participants to help design an intervention to better manage and reduce RTIs in young children. So, but for the purpose of today's presentation, I have selected an example of potential behavioural change in the area of inappropriate antibiotic prescribing, including delayed prescribing. So if we go back to the COM-B model, the TDF and the COM-B model, as mentioned before, just to recap, for any given behaviour to occur, there's three components, which is capability, opportunity and motivation have to be met, and these are listed in the left side column. So to identify what needs to be changed, we need to work out what needs to happen for the target behaviour to occur, and is there a need for change. For example, for this target behaviour to change, we're talking about delayed prescribing. So do they have the physical skill to not prescribe antibiotics? Because they have to have that capability. So no change is needed because GPs should all know how to not prescribe antibiotics. However, if we look at the opportunities, so GPs have commented that there's not enough consultation time to educate the parents on antibiotics, therefore it's easier to just write a script. So what needs to happen for this target behaviour to occur is we need to allow more consultation time for the GPs to educate parents on antibiotics. So change is needed as practice need to allocate more consultation time. So in terms of motivation, one of the motivation I've identified was GPs thought that parents expect antibiotics. So for that to change, GP needs to hold a belief that parents do not expect antibiotics, so therefore do not need to prescribe. So is there a need for change? Well, yeah, GPs need to understand and need to be reassured that parents do not necessarily expect antibiotics at consultation. So in this PhD, we're able to achieve the aims of the study that we set out to find. We used an approach which include other primary care providers, such as practice nurses, maternal child health nurses, and pharmacists in our research into the management and prevention of RTIs in young children. While previous studies have only focused on one healthcare professional with or without parents. We're also able to identify barriers into management and prevention into RTIs. We were able to compare and contrast not only views from primary care providers, we're able to compare their views with parents and carers with children under the age of 5, which we can then use to specify our targeted intervention. And also the framework, TDF, and the COM-B model we used in the study provide us with a robust methodology which will result into development of an evidence-based intervention to better manage RTIs in young children. So I'd just like to leave you with a last slide, a guide to academic relationships. So same department, same field, we call colleagues. Same topic, same field, we're collaborators. Same field, different topic, we're conference buddies. Different fields, different topic, who cares? And same field, same topic, we're bitter enemies. So just want to thank, acknowledge and thank RACGP for the Family Medical Care Education and Research Grant. Also NHMRC for my postgraduate scholarship and all the participants involved in the project. Thank you. I just realised I'm actually quite short. So any questions?
I'll come up and help facilitate. So has anyone got any questions for Ruby about that work? It's such a lot of work you presented in a short time.
It's only a little bit of yeah.
It occurred to me when I was listening that when you commented on the GPs needing more time to talk to the patient, we are expecting them to convey a lot of information and change and ingrain possibly attitude. Do you think that a lot of that education can happen outside of the consultation, and how, any ideas from your qualitative work about how parents might receive that information in other ways outside of the GP?
Yep, that's actually a really good question because I went to one of the conference last year and there was a paper presented that it doesn't take any more time to educate the parents as to writing a script. So, but there was a bit of, fault in the paper as well, but that was what they were trying to say. It doesn't take much more time. So maybe GP only has a 15-minute consultation, really, 10, 15 minutes, and they've got a lot of information that they have to let the parents know. A lot of GPs also complain that when parents come in, it's not just a one main problem that they're talking about. They're actually talking quite a few different problems. So they really do run out of time, and it is easy to write a script. So you're right, maybe we should be targeting parents and carers to educate them as to what symptoms you'd be looking for, why antibiotic is not, it's not the treatment or do-all end-all for respiratory tract infections. No matter how much a child is screaming in the middle of the night, there may be something else going on, and not just antibiotics may not be suitable for RTIs.
Ruby, there was a strong signal of quite significant differences across different cultures in the previous data, and did you get any signals of that in the work that you did?
You mean cultural differences?
Yes.
I didn't really, I sort of purposely not gone into the cultural difference because I know there would have been a lot of work ahead of me without that factor involved as well. We did try to target the lower socioeconomic area. So if you see the focus group initially were from the southeastern side, so the Dandenong, the Cranbourne, the Cardinia type area. But we actually found the parents who were interested in the topic, wanted to participate, were a little bit high in the socioeconomic scale. So it ended up that biased my research a little bit. So one of the comments at one of the presentation on the dissonant views was that looking at your data, most of your parents, like more than half of your parents have degrees and PhDs. So I'm like, oh, okay, that's a problem, because then of course there's a dissonance between, because they should be a little bit more educated. But that didn't affect the influenza view that influenza vaccine would give you disease. So it depends on what they wanted to talk about. And the other limitation I want to mention with my study that I didn't put up was I'm able to run focus group with parents and carers in a very comfortable, or in a sense comfortable, it was in a couple of play groups that there's screaming kids around, but to them it's a comfortable environment. Their views may be very different if I was recruiting them at a general practice when the kids are screaming because they have got RTIs and they were in pain. So I just want to mention that there may be a bit of bias in it too.
Even at the council that I'm in, the kindergarten programs have started hand hygiene programs when the children enter the room to wash their hands, and that's been put to parents solely as a preventative measure for anaphylaxis and allergies amongst the children. So do you think like it matters? Like that it seems to be an effective way to put it to parents that we're doing this to avoid, a serious incident rather than, I don't want to say just reduce transmissions of RTIs, but it's been accepted that way?
My kids are a lot older than childcare environments, so I haven't been involved in that area. That's quite a very good point, because I think a lot of the parents said, well, my kids know when to wash their hands because we told them when to wash their hands. They are very worried that there's a lot of bacterial stuff going around, and they're worried that the kids have been too clean. So, and they're also worried the kids are having OCD. So I think the message was loud and clear even from the primary care providers and the parents that good hand hygiene practice should be instilled really early in life, like literally from baby, good modelling, seeing the parents washing their hands at certain times. Then it could, reduce the possibility of OCD that kids are coming out, or the fear of OCD that the parents fear the kids are having. So one way maybe to say, or allergy could be a good way to, wash the hands.
It's something that's come out sometime in the last 4 years, because it wasn't a practice when my son started, but now it is. The kids have to walk into the room and wash their hands before they sit down.
Yeah. No, because they take their lunches, could be peanut butter or whatever, that they don't anymore.
I think that we're child eating peanut butter on toast for breakfast and then walking in
touch the table,
touching the child or the member of the side.
We're going to have to wrap up because I think somebody else is taking over the room. But thank you very much, Ruby, and that was an excellent presentation. And thank you to everyone for tuning in. And we just want to grab 30 seconds at the end to wish Jaclyn all the best for her wedding, because she's been working very hard on her PhD while trying to organise a wedding, and it's all happening remotely. And we have a gift here for you, Jaclyn, if you're still online, and we'll save it for when you come down to Melbourne to open up. But good luck, and we're all thinking of you. Thanks.
Thank you.
We'll sign off.